Greetings. Let us learn about spontaneous bacterial peritonitis. This is a dreaded complication of cirrhosis patients with ascites. So these are my acknowledgements, and please take time to read this notice. So spontaneous bacterial peritonitis, that is infection of the peritoneal cavity in patients with ascites without a source like a perforation or diverticulitis. So, whenever you see a patient with cirrhosis and ascites, you should consider spontaneous bacterial peritonitis if they come in with uh, change in their clinical status. If they complain of abdominal pain or an examination, you find tenderness, they notice worsening of their hepatic encephalopathy or worsening of their kidney function or changes in their blood counts. You should have a high index of suspicion for spontaneous bacterial peritonitis. And you should also consider spontaneous bacterial peritonitis if they have any symptoms related to the abdomen. Also, keep in mind it's not just abdominal symptoms. Think about neurological deterioration, think about renal function deterioration or deterioration of the liver function. You should also consider that in any patient who comes into the hospital admitted for any reason, you should rule out spontaneous bacterial peritonitis. And how do you diagnose spontaneous bacterial peritonitis? This involves taking fluid from the peritoneal cavity by doing paracentesis. And as we talked about, the best site for paracentesis is in the lower abdomen, left lower quadrant, where you have less chance for hitting any intra-abdominal organs, especially colon. And when it comes to inserting a needle after disinfecting the skin, you take a Z-track, make a Z-track to enter the peritoneal cavity. When a patient has tense ascites, you can obviously percuss and find a dull spot and put the needle in after uh, using local anesthetic and after disinfecting the skin. And what do you do with the fluid? You need to do a few things with the fluid. One, you want to send the fluid to a lab for cell count, especially polys. It's also a good idea to check the albumin and protein and take at least 10 cc's of acidic fluid and inoculate into the blood culture bottles, aerobic and anaerobic culture bottles at the bedside, at least 10 ml. And you will get basically two types of results. You'll get an idea about the cell count to see if there is increase in the polymorphonuclear cells in the acidic fluid. And you will also know whether there is a bacterial infection, if the culture is positive. Is it for one organism or multiple organisms? So let us learn about certain definitions regarding spontaneous bacterial peritonitis. So when you look at the fluid, uh, if the polymorphonuclear count is more than 250 per cubic millimeter, that indicates that there is obviously peritonitis. And if the culture becomes positive, usually in spontaneous bacterial peritonitis, it is only one organism, typically gram-negative, E. coli, Klebsiella, etc. And this is classic spontaneous bacterial peritonitis with elevated polymorphonuclear count, that is neutrophil count, above 250, and just one organism positive on culture. This is quite rare. Most of the time, you don't see culture positivity despite having spontaneous bacterial peritonitis. And how do you manage these patients? The management is giving an antibiotic, typically third generation cephalosporin. On the other hand, you may encounter a situation where you have just increased PMN count of more than 250 per cubic millimeter, but the culture is negative. This is defined as culture negative neutrocytic ascites. This is also considered equivalent to SBP, and we manage it as SBP with a broad spectrum third generation cephalosporin. So we talked about SBP, we talked about culture negative SBP or culture negative neutrocytic ascites. Sometimes you may see polys are not increased, but culture is positive for one organism, and this is defined as monobacterial or monomicrobial bacteria ascites. This also requires treatment for SBP. So we talked about polys increased, culture positive, polys increased, culture negative, polys not increased, culture positive. So we talked about all those things. So the next thing is you have here not one microorganism. As you can see in the slide, there are gram-positive, gram-negative, and different cocci, bacilli, and you have lots of polys, increased polys, and culture is positive, but multiple organisms. And this means that the patient is at high risk for problems. This is polymicrobial bacteriocitis, and this patient, unlike classic SBP or neutrocytic ascites or bacteria culture negative neutrocytic ascites or mono microbial bacteriocitis, where we just give single agent third generation cephalosporin. In polymicrobial bacteriocitis, you may need to give broad spectrum antibiotic. Something to keep in mind. This is a much more aggressive disease. On the other hand, when you see lots of polys in thousands and culture positive for multiple organisms, you should think whether the patient had a gut perforation and leading to secondary bacterial peritonitis. In this case, you not only treat with broad spectrum antibiotics, but also consider a surgical consult. You may need to do imaging studies to define the problem further. So we talked about SBP, culture positive, and polys increased. Neutrocytic ascites, just neutrophils increased, culture negative. Bacteriocitis monomicrobial, that is just the bacteria present on cultures, ascitic fluid polys not increased, about 250. Then we talked about polymicrobial bacteriocitis and secondary bacterial peritonitis. So something to keep in mind as you think about these patients. Sometimes you do a paracentesis and the lab says, hey, polys are increased, but there are lots of RBCs. And how do you know, how do you account for the RBCs to define whether the patient has SBP or not. So in that case, it's a simple calculation. You subtract 1 PMN per 250 RBCs, and based on that calculation, if it is still above 250, you know that the patient has spontaneous bacterial peritonitis. So we talked about different types of infection of the peritoneal cavity, and how do you diagnose based on cell count, presence or absence of organisms, one organism or multiple organisms, and how do you make adjustments when you see lots of RBCs. So coming to treatment, it is anytime you see a patient that comes into the hospital with ascites, make sure you check the ascites. Don't leave it till next day. Make a tap, check it for cell count, send it for at bedside cultures, and if the count is high, it is important to treat them promptly. When it comes to treatment, there are three important principles. One is giving an intravenous antibiotic. When it comes to intravenous antibiotic, in a typical case of spontaneous bacterial peritonitis, cell count increased, neutrophils more than 250, with or without increased, uh, without with or without culture positivity, or culture positive but less than polys of 250. All of those you manage them with intravenous third generation cephalosporin. Typically you use ceftriaxone. And you give it at least 5 days of treatment, 5 to 7 days. And then in addition to the antibiotic therapy, you should also treat this patient with intravenous albumin. You know that when you have cirrhosis, the patients already have defect, uh, decreased effective circulating volume because of vasodilation, splanchnic vasodilation. When you add infection, that component gets worse, and it increases the counterbalance hormones, renin-angiotensin, aldosterone system, increases sympathetic outflow, increases arginine vasopressin. All of them are pushing the kidney to hepatorenal syndrome. You want to avoid that by giving intravenous albumin. So in addition to antibiotic, you give intravenous albumin. That is, on day 1, you give 1.5 grams per kilogram of albumin, and on day 3, you repeat it. On day 3, you decrease the dose to 1 gram per kilogram of albumin. And this is very important. SBP is not just about antibiotics, but also countering the worsened hemodynamic status of these patients. So keep in mind that. As we know, patients with, by the time they have ascites and decompensation, the patients are on beta blockers to prevent variceal bleeding. And what do you do with the beta blockers? Should you stop or not? If their mean pressure is less than 65, it's a good idea to hold the beta blockers. That is until they get better, and by the time they get discharged, you could consider restarting. So something important to keep in mind. So hold the beta blocker. So you've treated the patient with SBP. You've been very good in giving them IV third generation cephalosporin. You gave albumin. You held the beta blocker, and you also need to see whether you're going in the right direction or not. You follow the patient's status. Usually they can get worsened with their hepatic encephalopathy. They can get their kidney dysfunction, follow that. And you want to see whether your antibiotics are taking care of the infection in the peritoneal cavity. So you repeat the paracentesis, typically done about 2 days later. At 48 hours, you repeat. And how do you know whether uh, your antibiotics are taking care of it? So you look at the cell count. And if the polys decrease significantly by more than 25%, you know that you're going in the right direction. On the other hand, if the polys do not decrease uh, by more than 25%, they're less than 25% decrease compared to the baseline, then you have to think about your antibiotic choice. The patient is on third generation cephalosporin. Maybe you have to broaden the coverage by adding piperacillin, tazobactam, or carbapenem. So something to keep in mind as you manage these very sick patients. And finally, if the patient is getting better, since the patient has had spontaneous bacterial peritonitis, it is important to prevent recurrence of spontaneous bacterial peritonitis, repeated infection. So you may have to put them on secondary prophylaxis and typically given as ciprofloxacin. The other one that you could try is Bactrim. And these are the two drugs that can be used for patients with spontaneous bacterial peritonitis when they go home. You also want to think about if they are on PPIs and they don't need PPIs, if they don't have an ulcer, they don't need PPI, you may want to hold their PPI because PPI can increase the bacterial overgrowth and could increase the risk of spontaneous bacterial peritonitis. As their blood pressure returns, make sure you restart their beta blocker. And if the patient is on diuretics, you held the diuretics for whatever reason, you may need to restart their diuretics to increase the opsonine content in the peritoneal cavity so that it reduces the risk of uh, repeat episodes of spontaneous bacterial peritonitis. So the key is suspect, have a high index of suspicion for spontaneous bacterial peritonitis in any patient that changes his clinical status or comes into the hospital, or anytime you do paracentesis, it is a good idea to send for cell count and act on that. The treatment is simple. Consider broad spectrum intravenous antibiotic, typically third generation cephalosporin intravenously. Always keep in mind that the system, the hemodynamic, hyperdynamic circulation is revved up in these patients, probably worsened with infection. You want to help that by giving intravenous albumin, 1.5 grams per kilogram day 1 and 1 gram per kilogram on day 3. Always check whether the patient is getting better or not by repeating the tap and send them on antibiotics to prevent recurrence. Hope this is helpful. I want to thank authors of this beautiful guideline from the American Association for the Study of Liver Diseases. Thank you.